Hello, everybody. I cannot tell you guys how excited I am to be here. I am practically jumping out of my skin. I have a lot to share with you, and I have a presentation that is about 35 slides long. So I'm going to go through this as quick as possible. You guys have my main title slide up there. Let me grab this, and then quickly, just because I do believe that it is a little helpful to hear where I am coming from. I'm going to go through my letters very quickly. I am a Master of Human Physiology. I also have, there you are, okay. Corrective exercise specialist, pre-postnatal corrective exercise specialist, fitness nutrition specialist, women's fitness nutritionist, women's fitness specialist, certified personal trainer, and then also Ehlers-Danlos syndrome, POTS, MCAS, UCI, Eagles. I have the ossifying stylohyoid ligament, and then also excessive heterotrophic ossification, autism, borderline personality disorder, which they now think has more to do with the autism and the childhood trauma. And I can also tell you guys, dialectical behavioral therapy, which we heard about earlier today, that is a lifesaver. That changed my life, and it is amazing for chronic illness. So that's what I'm saying there, quick plug. I started my journey at 15 in pharmaceuticals, spent 6 years there. I was managing animal facilities. By the time I was 22, moved on to become an unlicensed surgical technician for a veterinary corporation for a little while, and then went on to become a licensed high school teacher for 10 years while I was getting my MS. And then I had my crash and became very sick. So left teaching, and then I became a full-time pro athlete, because apparently that's what you do when your body falls apart on you. And I got my certification as a personal trainer. I was on American Ninja Warrior. I was a professional sponsored obstacle course racer for a few years. Then a 2016 dislocation ruined me. And then since 2018, when I got my diagnosis, I have done nothing but continue my biomedical research on hypermobility. And here I am to teach you guys about breathing today, so we're gonna get started. All right, and I'm gonna be working from my computer while you are looking at those slides. So, perfect. The outline, very quickly, what we're gonna cover, why we use prescriptive breathing, diaphragm dysfunction, what leads to it, known causes of diaphragm dysfunction. I'm gonna touch on a lot of these briefly. We've kind of gone through a lot of these already today. Previous presentations have all been incredible so far. And then I'm gonna hopefully end with making a big stink about rib cages, better diaphragmatic breathing, and how we can utilize our pressure canister a little bit better. I'm sorry, I'm gonna be speaking a little bit quickly today. These slides are online. I do have all my references. I want to give you this information, so I'll move fast. So why use prescriptive breathing? Spines will collapse under 2.5 pounds of pressure unless our muscles and fascia hold them up. Activities of daily living place between 20 and 200 pounds on your spine. Walking alone is 2.5 times your body weight on your spine. So when we cough, sneeze, run, pick up heavy boxes, or move anything, we are trying to stabilize our spine reflexively so that we can transmit force through our body to carry out these activities. And when you are hypermobile, your body will do that any which way it can. And after years of injury, proprioceptive difficulties, and all kinds of insults accumulating, our risk of injury goes through the roof. So, if synergist muscles, which are supposed to be associative, helpful muscles in a movement, take over and become your prime movers, then the spine does not stabilize effectively for safe loading and force transmission, and then the risk of injury goes up. Prescriptive breathing works the same as any prescriptive exercise program that a PT or a corrective exercise physiologist could supply for you. And you want to progressively load over time. I'm losing my notes here, hold on. Yes, over time, healthier recruitment patterns become neurologically more stabilized in our system through a process called long-term potentiation, and then our body will start to recruit those neurological patterns a little bit more effectively on a second nature basis, as opposed to having to think about them over time. Although, caveat, we will always have to think about where our body's in space. It's kind of part of the deal when we move so much farther past a normal range of motion. All right, we can in fact build muscle and strength. There are support studies that show this. It does take a bit longer. We do have a delay with recovery from injury, but we do have the capability of building enough fascia, denser muscle that we can support and stabilize, and neuromuscular connections that we can actually use our bodies more efficiently. So diaphragm dysfunction, I'm going to talk a lot about this. Diaphragm dysfunction also impacts nervous system, Gastrointestinal health. I really encourage you guys to listen again on Saturday to Dr. Patty's lecture on mouths. That'll relate a lot to this. GI dysfunction, immune system functioning is directly related to your diaphragm dysfunction, musculoskeletal function, and then the rest of your body. It's just pretty much everything. If your diaphragm doesn't work, the rest of you doesn't work so well. So there's also functional defecation disorders that go along to this too. I bet that a lot of people in this room, I will be blatant, probably suffer from some form of constipation or otherwise diarrhea or urinary problems that go along with it. When your diaphragm doesn't work, pelvic floor doesn't really work. There's other diaphragms involved in the body that go along with this, but those are the two I'll talk about. So we also know that diaphragm dysfunction can highly disturb your sleep. There's a lot of ways that it can do that. It leads to exercise intolerance. And then forward head posture, which is one I'm going to come back to quite a bit, especially when I pull up my little rib cage here. Okay. All right, so causes of diaphragm dysfunction. Stress, right? Hold your breath a lot. Chest wall deformities, shallow breathing, which a lot of people are subject to. Spinal muscle atrophy, which a lot of us experience. Nervous system trauma from child injury, illness, loss, anything. Chiari malformation, asthma, vascular incidents. It goes on and on. So, rethinking what breathing does for the body. Diaphragm doesn't just help us get oxygen in, carbon dioxide out. It reinforces posture alignment. It's a postural muscle. It also manages GI pressure. It helps to regulate motility in your system, manages oxygen, carbon dioxide levels, balances your sympathetic nervous system and your parasympathetic nervous system. And effective breathing translates to efficient force transmission. And that's the root of why I do this with all of my clients. If they can't effectively breathe on an exhale or stabilize their spine with those muscles, then I can't have them lift weights or move things or carry out activities of daily living efficiently. So nasal breathing also, I just wanted to put this in here because overnight, if you are a mouth breather, you are dehydrating yourself. You lose up to 42% of your hydration water overnight while you sleep if you are breathing through your mouth. So mouth tape, if you can't do mouth tape, there's slings. Shout out to all the myofunctional therapists who have spoken earlier today. Go back and look at their lectures too. So continuing to rethink what the body does, breathing does for the body. It's also an emotional regulator. We know this, the research is there now. It's quite popular in science. Slower respiration correlates with higher senses of well-being. Nasal breathing is associated with better modulation of the emotional limbic system and learning. You actually retain and cement information better on an inhale than you do on an exhale. And bonus points for your brain if you do it while you're doing it through your nose and not your mouth, which decreases how much you can actually learn. Crazy. So 70% of people with panic disorders, and that's just general population statistics, and some anxiety disorders are chronically hypocapnic, means that their CO2 levels are too low. Mine rests at about 18. It's silly low for somebody who specializes in breathing. And that definitely affects your ability to modulate anxiety in your sympathetic nervous system. So research indicates prescriptive breathing can be used to disrupt neural circuits for stress and anxiety over long term. There are physiological changes that can occur. Huberman's lab did a great paper. There's been some other great respiratory research recently that supports this. And these have already been listed in other presentations earlier. Respiratory characteristics identified in EDS. I'm not going to go through each of those right now because we've seen them. This is what I tend to see the most in my practice. So people with hypermobile HSD EDS have been shown to have weak inspiratory muscles. There is research on that. In clinic, anecdotally, a lot of people have an infrasternal angle that is below 90 degrees. And then this is often accompanied, in fact, I don't think I've ever seen it accompanied without a breathing pattern disorder. And then on the exhalation side of things, I also see a lot of dysfunction there as well, equally in fact. But they are two different things. So we have rhythmic automatic breathing, which is controlled by something called the pre-Bottzner complex, and I'm not going to go into the neural. There's other people who can describe it better. But there's other multiple centers involved in not only conscious breathing and non-rhythmic breathing, but also exhalation that goes beyond the inhalation portion of this. So resetting and rewiring breathing patterns requires work on both sides of this process. And then, so just quickly, so infrasternal angle. Right here at this junction, we typically want to see approximately a 90-degree angle between the two ribs. Most people I see tend to be dropped a bit lower. So I'd say between like 60, 70 degrees. And then if I turn my little rib cage here to the side, you guys don't have me on the screen. If you could take a picture of this, I don't know. If I collapse it in down around the 5th and 6th rib, you can see that the sternum starts to bow in. And I'm going to be showing you pectus excavatum in just a second here. And you can also see that the bottom ribs tend to flare out. And if I'm holding the spine stable down here, then it curves the top of the spine. And how many of our clients have complaints about shoulder blade pain there or upper traps? When you have a drop infrasternal angle, that promotes a lot of muscle tension patterns and locking of the diaphragm in a way that you have to use these alternate muscles to help get inspiration. And tidal volume, we passively breathe at about 500 milliliters. We're only using your diaphragm. There's not a lot of assistance muscle. But anytime you're doing a big breath, right, or you're picking something up or pushing, then you're going to be using more of those muscles. And those secondary muscles, if they become stronger and stronger over time, they're going to continue to push you out of alignment, make this shoulder blade detach farther off the back. They can push you into forward head posture, and suddenly your 12-pound ball up here is now 60 pounds when your head is 60 degrees forward off of the base of your neck. So there is a massive amount of mechanical implication that goes along with where your ribs are actually sitting. So back on track. Okay, I'm trying to fly through. I hope you guys are sticking with me here. All right, inhalation, musculoskeletal issues. These are what I see a lot of. Weakened inspiratory muscles, diaphragm, intercostals, reduced infrasternal angle, just explained. Shallow hyperventilation breathing patterns are super, super common. If you look up any hyperventilation breathing and you look at the list of qualifications, it tends to go along with everybody that has ribcage disorder and pretty much everybody I see. A lot of overusing of scalenes, sternocleidomastoid, upper traps, lumbar erectors, especially on big inhales and especially if there's some sort of rib cage issue. And then excessive pelvic floor tension. Now, pelvic floor, very quick. I think I come back to it, but I'm going to mention it super fast. Pelvic floor, you've got a front, you got a back, and you got two sides. And just like your diaphragm, you got two sides and you got a front and a back, they can get jammed up in any one of those four quadrants. So you can get parts that are really tight and pulling your entire pelvic floor anatomy in one direction. Same thing with your diaphragm. You can get parts that get really tight or stuck or frozen. And if you've got flared ribs in the front of your diaphragm get stretched out, that affects something called the zone of apposition, which is really important and indicative of hyperventilation syndromes and a lot of other kind of correlative symptoms that we see commonly with EDS presentations. Okay. Exhalation, musculoskeletal issues. I rarely see front pelvic floor activating the way that it is supposed to. If people are exhaling forcefully, I say blow out like you're blowing 100 birthday candles out. You'll often see a belly pooch, and that can be often indicative of a massive amount of pelvic floor pressure dropping down, okay? And then we all know hernias and prolapse, those are even on the current diagnostic criteria and part 2 as things that are related to Ehlers-Danlos syndrome. Those happen when you have pressure mismanagement. So if your diaphragm, your abdominal muscles, pelvic floor aren't syncing up in a way that promote healthy exhalation with spinal stability, and we're using all those secondary muscles, then we increase the risk of injury, including prolapses, spine, pelvic floor, anywhere, abdominal. All right, so common dysfunctional breathing patterns. I think I'm gonna show you here. Okay, take a quick sip. How much time do I have? Sorry. Thank you. Okay. Now for the live demonstration portion. Okay. And I'm going to come back to pectus excavatum and carinatum in just a minute. Should I show that now? Maybe. All right, quick run through and then I'll come back to it. Okay, so a major common disorder when people take a really big breath in, I see a lot of rib cage shifting up or tilting up. So we end up with tight, high hinge points, and we end up with rib cages that don't stack nicely over the pelvis with pressure mismanagement all over the place here. The reverse and the paradoxical breathing I'll show in just a second, high hinge patterning and belly breathing I'll show in just a second. Okay, belly breathing I have beef with. I'm sorry, I'm so sorry. When you're belly breathing and you are just, I can't even do it, getting the belly to come out, you're not actually necessarily using your diaphragm in that case. There may be other muscles that are trying to pull air into your system, and that can actually create a weak point, and that can help to promote weaker, not only lower transversus abdominis muscles, but the front pelvic floor as well. So I don't love belly breathing. I like to use something called 360 breathing. I want to say the term, I don't think it was coined by Dr. Sarah Duvall. It might have been, but she uses it the most. So chest wall deformities, come in here. Okay, pectus excavatum. I think personally that this is underdiagnosed, especially in women. They say that connective tissue disorders of the rib cage are not as common as they are in Marfan syndrome and other connective tissue disorders. I don't think that's the case. They say it's more in men, not women. If you look at me, my rib cage looks fine. I have a bra on. If I show you here, and turn off to the side, you can see I got a massive dip. My sternum completely caves in here so that when I go to try to take a really good inhale, my sternum does not lift. And if I didn't have appropriate mobility in the facets of my rib cage in the front and the back, being able to do some of the extra work that my diaphragm is not quite able to do, then I wouldn't be able to get a maximum breath. And in fact, what actually happened for years when I would take a big deep breath, and you might have just seen that, is my sternocleidomastoids, mastoids, my big neck muscles and my upper back muscles would take over. So by the time I was 30, I had 3 herniated discs in my neck and 7 in my back, and I was still doing professional sports. So my head posture, I would see pictures of myself in races and my head would be all the way out here because by 6 miles in, I couldn't breathe. There was nothing happening here. So pectus excavatum. I do encourage everybody to kind of learn a little more about this, and also carinatum and arcuatum, which is a combination of the two of them, because I have a feeling you'll see them a little bit more often if you know what you're looking at. Anytime you see something that looks like rib flare down here, or if you look at a patient and they have an angle that's dropped below about 90 degrees in that infrasternal space, then you might be looking at somebody who has one of these chest wall deformities. Now, if you can't expand, and that sternum can't lift like a water pump handle, you cannot pull air effectively into the body, so you will get compensation muscle patterns. All of those can lead to upper cervical instability and everything else that we've talked about and heard about today. So EDS, HSD bodies are famous for compensation. So when our bodies, which are very plastic and hypersensory, when we put that type of stimulus in them to learn that pattern, they really learn it. Carinatum, just to very quickly bring it up, is a little bit like the opposite, where instead of a bowing in, you have a pigeon chest out. So if I take my little sternum here on this guy, because I don't have this, and then I just kind of push up and out on the T1-2 area, you can see how that would push the ribs up and forward. And then we heard a little bit about thoracic outlet syndrome, compression, vascular numbness, tingling in the fingers. This is not the only cause of this. In fact, I don't see this in as many cases as I hear of the numbness and tingling, but it's an association. When the rib cage is pushed forward, you're putting pressure on brachial complex. You also have compression on vasculature in that area, which can inhibit how well you get venous flow and nerve conduction. Okay, so I love this picture. I just had these drawn up for this conference. The one on the right, I'm going to focus more on. The one on the left does show pectus excavatum, but the right, if you have a sternum that is pushed in at the manubrial junction right there, and you can see how that would actually kind of impact how much space you have for your ribs to expand and for your lungs to fill up. This can affect your heart and a whole bunch of other stuff, right? I wish I had more time on that. I'm not going to do penticulation. Oh, I wish I could. Okay. And then, okay, so breathing assessments, if you are in movement specialty PT doctor, these can give you an idea of if you patient is suffering from some sort of altered dysfunctional breathing pattern, the MARM, the high-low, and the CO2 tolerance test. And then for exercise interventions, the physiological side was already brought up once. I'm not gonna spend time on these. There's plenty of research and you can look those up. Okay, physiological side was already brought up once yesterday, I wanna say, where you do a maximum inhale, followed by a complete exhale. I use this about 20 times a day, and I encourage you guys all to take this to heart too. This will actually switch your system from sympathetic state of activation towards a parasympathetic state. It is a physiological trick to help reset yourself and drive yourself into a calmer situation. Okay, clamshell reset. I love this one too. If you have somebody whose diaphragm is really stuck and they're not able to quite get a breath without some sort of big heave or dysfunctional breathing pattern, then you can throw them on their side. Don't throw them, just have them lie down on their side, bend their knees, and then you're gonna have them take a regular inhale and exhale. I do it for 5 seconds just because it kind of helps give them something to count and time with. But what really matters is at the bottom of the exhale, they hold their breath. Then you have them do an abduction, followed by adduction, bring it back together, 5 seconds on each one, and then have them inhale through the nose. And on the next round of inhale, you will see much better back expansion. The back of the diaphragm will kick in, they'll get a much more complete breath, and you can see them visibly relax. Their fascia just, let's go, and it's really amazing. So I encourage you to take a closer look at that and try it. I'm not going to show the video, so hook-lying breathing, again, they're in there, and I know I promised I would show these to you. 5th time you guys have heard of mewing tongue in the last 2 days. Again, take this to heed. You should have the tongue up, back, roof of the mouth. That's where it would ideally like to sit. And again, scapular retraction. Okay, so very quick exercise progressions just because it is important. Supine to seated to standing, okay? We always want to start with supported, meet the body where it is, fully posture balanced, and then we work on gently increasing load. We do this with exercise and PT regardless, but we have to remember with the hypermobile people that the level of load required for change is so much lower. We have to start at a baseline that is even more baseline than you ever could have imagined when you first got into some sort of movement or PT therapy, right? And then when we add 10% each week, that those little increments are teeny, 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 weeny, just because it's such an exponentially smaller starting point than if we were higher up on that curve where we could gradually progress faster like typical functioning people, if that makes sense. Okay. 3 full pages of references for you guys to peruse through when you have all that time. And thank you so absolutely very much for letting me share with you today. Bless you.